Infective endocarditis. Infective endocarditis is an infection of the endocardial layer of the heart. It also affects the cardiac valves. Treatment of IE with antibiotic therapy has improved the prognosis of this disease. Though relatively uncommon, an estimated 10,000 to 15,000 new cases of IE are diagnosed in the United States each year. The endocardium is the innermost layer of the heart and the heart valves. Therefore, IE affects the valves. IE was traditionally classified as subacute or acute. The subacute form affects those with pre-existing valve disease and has a clinical course that may extend over months. In contrast, the acute form affects those in healthy valves and manifests as a rapidly progressive illness. Today, IE is more often classified based on cause. So, intravenous drug use is an example. Fungal endocarditis is another example. Or if there was site involvement. So, a couple examples, or one example I should say, is prosthetic valve endocarditis, or PVE. The most causative organisms of IE are Staphylococcus aureus and Streptococcus viridans. Both are bacterial. Other possible pathogens include fungi and viruses. IE occurs when blood flow within the heart allows the causative organism to infect previously damaged valves or other endothelial surfaces. IE can occur in persons with a variety of underlying cardiac and noncardiac conditions, as well as those undergoing invasive procedures. You can take a look at table 36-1 in your textbook. At one time, rheumatic heart disease was the most common cause of IE. Now it accounts for about less than 20% of the cases. The main contributing factor to IE includes 1. Aging. More than 50% of older adults have calcified aortic stenosis. 2. IV drug use. 3. Use of prosthetic valves. 4. Use of intravascular devices resulting in healthcare-associated infections. And 5. Renal dialysis. Vegetations. The primary lesions of IE consist of fibrin, leukocytes, platelets, and microbes that adhere to the valve surface or endocardium. The loss of parts of these fragile vegetations into circulation results in embolization. This is a picture of vegetations growing on the mitral valves. Here's another picture of mitral stenosis and vegetation. This diagram depicts the pathogenesis of IE. Once vegetations occur, they can break off, causing emboli. Many persons with IE will develop systemic embolization. This occurs when left-sided heart vegetation moves to various organs, for example, the brains, kidneys, and spleen, and to the extremities, causing limb infarction. Right-sided heart lesions immobilize to the lungs, resulting in a pulmonary emboli. The infection may spread locally and damage the valves or their supporting structures. So they can cause dysrhythmias, valve dysfunction, and eventual invasion of the myocardium, leading to heart failure, sepsis, and heart block. The clinical manifestations of IE are nonspecific and can involve multiple organ systems. Symptoms include fever, chills, weakness, malaise, fatigue, and anorexia. Arthralgias, myalgias, back pain, abdominal discomfort, weight loss, headache, and clubbing of the fingers may occur in subacute forms of IE. Fever may be absent in older adults or those who are immunocompromised. Vascular signs of IE include splinter hemorrhages, so black longitudinal streaks that may occur in the nail beds. Go ahead and Google splinter hemorrhages, and you can then click images, Google search an image, and you can see some pictures of splinter hemorrhages. The book has some too. Petechiae may occur as a result of fragmentation and microembolization of vegetative lesions. They can occur on the conjunctivae, lips, buccal mucosa, and palate, also over the ankles, feet, antecubital, and popliteal areas. Osler's nodes, painful, tender, red or purple pea-sized lesions, may be found on the fingertips or toes. Janeway's lesions, flat, painless, small red spots, may be seen on the pads of the fingers and toes. Eye examination may reveal hemorrhagic retinal lesions called Roth spots. So the figure on the left here is Osler's node on the toe pad of the fourth toe. You can also see on the slide the multiple petechiae on the foot. On the right, it's Osler's node on the anterior surface of the distal finger. The purplish area was tender to palpation. On the left, Janeway's lesion. On the right, note the small painless nodules on the sole of the patient with bacterial endocarditis. Then you have Roth spots. The onset of a new or worsening systolic murmur is noted in most patients with IE. The aortic and mitral valves are most often affected. Heart failure occurs in up to 80% of patients with aortic valve endocarditis and in approximately 50% of patients with mitral valve endocarditis. So heart failure in 80% of patients with aortic valve endocarditis and approximately 50% with mitral valve. Clinical signs secondary to embolization may be present on various body organs. So embolization to the spleen may cause sharp left upper quadrant pain, local tenderness, and abdominal rigidity. Embolization to the kidneys can cause flank pain, hematuria, and renal failure. Emboli may dislodge in small peripheral blood vessels of the arms and legs and may cause ischemia and gangrene. Embolization to the brain may cause neurologic damage resulting in hemiplegia, ataxia, aphasia, visual changes, and change in mental status. Pulmonary emboli may occur in right-sided endocarditis and cause difficulty breathing, chest pain, hemoptysis, and respiratory distress. The patient's health history is important in assessing IE. Ask patients if they've had any recent, within the past 3 to 6 months, dental, urologic, surgical, or gynecologic procedures, include normal or abnormal obstetric deliveries. Note any previous history of IV drug use, heart disease, recent heart catheterization, heart surgery, intravascular device placement, renal dialysis or infections. So any skin infections, respiratory or urinary tract. Risk factors have already been discussed. 2 blood cultures are drawn 1 hour apart from 2 different sites, will be positive in more than 90% of patients. Culture negative endocarditis is often associated with antibiotic usage within the previous 2 weeks or due to a pathogen not easily detected by standard culture tests. Cultures that are negative should be kept for 3 weeks if the clinical diagnosis remains endocarditis because of the possibility of slow-growing organisms. A mild leukocytosis occurs in acute IE. This is uncommon in subacute. The erythrocyte sedimentation rate, or the ESR, and the C-reactive protein, the CRP, levels may also be elevated. Echocardiography is valuable in the diagnostic workup of patients with IE when the blood cultures are negative, or for the patient who has a surgical candidate and has an active infection. Transesophageal echocardiogram in 2 or 3 dimensional, so 3D, transthoracic echocardiograms can detect vegetation on the heart valves. A chest x-ray is done to detect cardiomegaly, which is an enlarged heart. An electrocardiogram, or ECG, may show first or second degree heart block. Heart block occurs because the heart valves lie close to the conductive tissues, especially the AV node. Heart catheterization may be used to assess valve function and the coronary arteries when surgery is being considered. Major criteria to diagnose IE include at least 2 of the following: 2 positive blood cultures, 12 hours apart, non-valvular regurgitation, or intracardiac mass or vegetation noted on the echocardiography. So you can look at table 36-2 in your textbook. Target groups for prophylactic antibiotics are people with the following heart conditions should have prophylactic antibiotics when they have the conditions or procedures listed here. Prosthetic heart valve or prosthetic material used to repair a heart valve. Previous history of infectious endocarditis. Congenital heart disease. Unrepaired cyanotic CHD, or congestive heart disease. Repaired congenital heart defect with prosthetic material or device for 6 months after the procedure. repaired CHD with residual defects at the site or adjacent to the site of the prosthetic patch or prosthetic device. Heart transplantation recipients who develop heart valve disease. Conditions or procedures needing antibiotic prophylaxis. So, when the above risk groups have the following conditions or procedures, they need prophylactic antibiotics. So, for oral procedures, dental manipulation involving the gums or roots of the teeth, dental manipulation involving puncture of the oral mucosa, respiratory procedures. So, respiratory tract incisions like a biopsy, tonsillectomy or an adenoidectomy, accurate identification of causative organisms is the key to successful treatment of IE. Long-term treatment is necessary to kill dormant bacteria within the valvular vegetations. Complete removal of the organism generally takes weeks to achieve, and relapses are common. Patients are hospitalized and IV antibiotic therapy. Based on blood cultures, patients are hospitalized and antibiotic therapy is started based on the blood culture results. We want to find out what we're dealing with and before we start treating it with antibiotics. The effectiveness of therapy is assessed with subsequent blood cultures. Cultures that remain positive and indicate inadequate or inappropriate selection of antibiotic. So, aortic root or myocardial abscess, or the wrong diagnosis. Maybe an infection is somewhere else. Fungal endocarditis and PVE respond poorly to antibiotic therapy alone. Early valve replacement followed by prolonged antibiotics is needed in these situations. Valve replacement has become an important adjunct procedure in the management of IE. Fever may persist for several days after treatment has been started. It can be treated with aspirin or acetaminophen or ibuprofen, fluids, and rest. Complete bed rest is usually not needed unless the temperature remains elevated or there are signs of heart failure. Obtain the following health information from the patient. So, past health history. We want to look at any valvular, congenital, or syphilitic heart disease, including valve repair or replacement, previous endocarditis, childbirth, staphylococcal or streptococcal infections, hospital-acquired bacteremia. We also want to look at their drugs. Are they on anything for immunosuppressive therapy? Surgeries and other treatments, recent obstetric or gynecological procedures, invasive procedures, including heart cath, cystoscopy, recent dental or surgical procedures, or any GI procedures like an endoscopy. Also obtain the following important health information related to pertinent functional health patterns. So, health perception, health management, any IV drug use, alcohol abuse, malaise, nutritional and metabolic, include weight gain or loss, anorexia, chills, or diaphoresis. Elimination patterns, are they seeing any bloody urine? Activity and exercise. Exercise intolerance, generalized weakness, fatigue, cough, difficulty breathing on exertion, orthopnea, and palpitations. For their sleep rest patterns, are they experiencing any night sweats? And and they're cognitive and perceptual. So we're going to look at their chest, back, or abdominal pain, headache, joint or muscle tenderness. Next, we're going to perform a focused physical assessment for the following clinical manifestations. So we want to look at, do they have a fever or not? We're going to look for on their skin, Osler's nodes on the extremities, splinter hemorrhages under the nail beds, Janeway's lesions on the palms and the soles, petechiae on the skin, mucous membranes we'll look at. We're going to look at the conjunctive, purpura, peripheral edema, and finger clubbing. When we assess respiratory, we're listening for increased respiratory rate, crackles in the lungs, and for cardiovascular assessment, we'll listen for the rhythm of the heart. So we want to check and see if there is a dysrhythmia. We're going to also assess for tachycardia. Are there any new murmurs, particularly S3 and S4? And we'll also look for any retinal hemorrhages. The overall goals for the patient with IE include normal or baseline cardiac function, performance of activities of daily living without fatigue, knowledge of therapeutic regimen to prevent reoccurrence of the endocarditis. The incidence of IE can be decreased by identifying individuals who are at risk for the development of IE. Assessment of the patient's history and an understanding of the disease are crucial for planning and implementing appropriate health promotion strategies. Teaching the patient at high risk for IE helps reduce the incidence and recurrence of the disease. Teaching is important for the patient's understanding of and adherence to the planned treatment regimen. Tell the patient to avoid persons with infection, especially upper respiratory infection, and to report cold, flu, and cough symptoms. Stress the importance of avoiding excessive fatigue and the need to plan rest periods before and after activity. Good oral hygiene, including daily care and regular dental visits, are also important. Tell the patient to inform their healthcare provider performing certain invasive procedures of the history of IE. Be certain the patient understands the importance of prophylactic antibiotic therapy before certain invasive procedures. You should refer the patient with history of IV drug use for drug rehabilitation. IE generally requires treatment with antibiotics for 4 to 6 weeks. After initial treatment in the hospital, the patient may continue treatment at home if hemodynamically stable and compliant. Assess the home setting for adequate support. Patients who receive outpatient IV antibiotics will require vigilant home nursing care. Monitor laboratory data to determine the effectiveness of antibiotic therapy. Ongoing monitoring of the patient's blood cultures is necessary to ensure destruction of the infecting organism. Assess IV lines for patency and signs of complications, for example, phlebitis. The patient may experience anxiety and fear associated with the illness. You must recognize this and benign strategies to help the patient cope with the illness. Give antibiotics as ordered and monitor the patient for adverse drug reactions. The patient with IE needs adequate periods of physical and emotional rest. Bed rest may be necessary when fever is present and when there are complications, for example, heart damage. Otherwise, the patient may walk and perform moderate activity. To prevent problems related to decreased mobility, teach the patient to wear elastic compression stockings, perform range of motion exercises, and deep breathe and cough every 2 hours. Fever, whether it's chronic or intermittent, is a common early sign. Tell the patient and caregiver about the importance of monitoring body temperature. Persistent temperature elevations may mean that the drug therapy is ineffective. Patients with IE are at risk for life-threatening complications such as stroke, PE, pulmonary edema, and heart failure. Teach patients and caregivers to recognize signs and symptoms of these complications. So, any change in mental status, difficulty breathing, chest pain, unexplained weight gain. Management will also focus on teaching the patient and caregiver the nature of the disease and on reducing the risk of reinfection. Explain to the patient the relationship of follow-up care, good nutrition, and early treatment of common infections to stay healthy. Teach the patient about symptoms that may indicate another infection. So watch for fever, fatigue, and chills. Tell the patient to notify the healthcare provider if any of these symptoms occur. And then finally, tell the patient about the need for and the importance of prophylactic antibiotic therapy before certain invasive procedures. The overall expected outcomes for the patient with IE include we want them to maintain adequate tissue and organ perfusion. We want them to maintain a normal body temperature. We want them to perform activities to minimize adverse changes in physical and emotional functioning. We want them to report any increase in physical or emotional. We want them to report an increase in physical and emotional comfort. And we also want them to be able to describe the disease process, appropriate treatments, and measures to prevent the reoccurrence of the disease.